And so that, I hope, is a segue to this conversation of a mutation in the calcium sensing receptor, resulting in this entity, again, FHH, which I will abbreviate moving forward. All right, so this is a disease that presents very similar to primary hyperparathyroidism in some of the electrolyte abnormalities that one might see. Patients present with mild, typically mild hypercalcemia, and the PTH is non-suppressed in that scenario, or it's overtly elevated. Again, that's just like primary hyperparathyroidism. Hypophosphatemia is another manifestation that is common with FHH, again, similar to primary hyperparathyroidism. And this highlights the fact that as you finalize a diagnosis of primary hyperparathyroidism, the main diagnostic dilemma is excluding FHH, because FHH, a benign condition, requires no further intervention, and specifically no parathyroidectomy, which would be a morbid outcome if you treated a FHH with a attempt at parathyroidectomy. So one has to make this diagnostic distinction when finalizing a diagnosis of primary hyperparathyroidism. Specifically, one must exclude FHH because it mimics primary hyperparathyroidism, with hypercalcemia, a PTH that is non-suppressed, and then often hypophosphatemia. Now, the distinguishing feature is in the name, the hypocalciuria. We talked about in our last discussion how in primary hyperparathyroidism, usually you see hypercalcemia, but that is not always the case. Okay, depending on vitamin D status, depending on GFR, one might not see overt hypercalciuria. But this is still a pivot point between making the diagnosis of primary hyperparathyroidism and FHH, the evaluation of urinary calcium excretion rates. Now, better than a 24-hour urine calcium would be a calcium to creatinine clearance ratio that would sort of minimize any effect of reduced GFR on interpreting a 24-hour urine calcium. Remember, we said that a determinant of calcium excretion rates are not just whether you're hypercalcemic and whether calcium sensing receptor is activated or not. One of the main determinants of calcium excretion rates is your filtered load of calcium, which is essentially equal to the free calcium concentration and the glomerular filtration rate, right? The filtered load of calcium is based on GFR. It's directly proportional to GFR. So if I have a reduced GFR, I might tend towards a lower urinary calcium excretion rate. The use of a calcium to creatinine clearance ratio corrects for that reduction in GFR in interpreting the urinary calcium excretion rate. Okay, so patients with FHH are typically asymptomatic, but that's not always the case. People have described in large series of FHH that sometimes patients have some non-specific symptoms that may be attributable to the hypercalcemia or the hypophosphatemia of FHH. Okay, but typically FHH patients have no clinical symptoms. Remember again, the etiology is a defect or is an abnormality in the calcium sensing receptor gene. What happens is that these patients have a lower sensitivity for calcium in this mutant calcium sensing receptor, right? So that means they need a higher, if this is the calcium sensing receptor, they need a higher calcium concentration in order to activate the calcium sensing receptor. that is to suppress PTH. Remember, activation of the calcium sensing receptor results in a reduction in PTH release. So these patients will have relatively higher calciums and non-suppressed PTH hormone levels. Okay, so again, this is a reduction in the sensitivity of the calcium sensing receptor to calcium. Okay, um, and we'll talk about the inverse of this when we talk about autosomal dominant hypocalcemia. Let's anticipate that conversation. That is another mutation in the calcium sensing receptor, but in that case, there is an activation of the calcium sensing receptor. So I need a lower calcium concentration to have that calcium sensing receptor fully activated, and the phenotype is hypocalcemia. So the name of that syndrome is autosomal dominant hypocalcemia. We'll talk about that when we talk about hypocalcemia, or when we reach the hypocalcemia chapter of the field guide. Okay, so these are mirror images of each other, autosomal dominant hypocalcemia and familial hypocalciuric hypercalcemia. Okay, so these are typically, again, heterozygous mutations that reduce the sensitivity of the calcium sensing receptor to calcium. When I have homozygous mutations, the result is a very severe phenotype in which these individuals will have profound hypercalcemia and hyperparathyroidism, right? So this is going to manifest in the neonate with severe life-threatening hypercalcemia, and then the PTH, which is non-suppressed. These are very high parathyroid hormone levels, okay? So the pathophysiology we've talked about in our discussions around primary hyperparathyroidism, and then the limited dive that I've taken into describing the calcium sensing receptor. We can go through this relatively quickly. Remember that the calcium sensing receptor is expressed in the parathyroid gland. I've emphasized that in describing the effect on PTH levels. But we'll also need to recall that calcium sensing receptor is present in the nephron as well. In the thick ascending limb is where it is most well described, but you have calcium sensing receptor throughout the nephron in the proximal and distal nephron as well. Okay, and that will result in the phenotype of hypocalciuria. So let's segue into why these patients have hypocalciuria, because again, they have, let's say, mostly intact GFR, they have relatively high calcium levels, so one would predict that those individuals will therefore have relatively high urinary calcium excretion rates. But if one were to recall that, again, I have a calcium sensing receptor throughout the nephron, and that calcium sensing receptor mediates calcium handling throughout the nephron, one can then make sense of the hypocalciuria that manifests. Remember, this is a decrease in sensitivity to the calcium. And so these calcium receptors in the nephron, sensing receptors in the nephron, are also detecting relatively low amounts of calcium. And because these calcium sensing receptors regulate calcium transport, Orson described a family of proteins that mediate transport through the paracellular route, or the paracellular pathway. These are claudins. These proteins are modulated by the calcium sensing receptor. So one would predict that these individuals with, again, decreased sensitivity of the calcium sensing receptor are sensing relatively low calcium concentrations, and so paracellular calcium transport is increased in these individuals. Okay, so these individuals manifest hypocalciuria because the nephron senses low calcium and so upregulates calcium transport. By and large, this paracellular pathway of calcium transport. Okay, so I've talked about some of these. I guess this point right here, calcium reclamation is enhanced by this insensitivity of the calcium sensing receptor throughout the nephron. Okay, so I think we can move on to this evaluation. Urinary calcium excretion rates are typically low. We use a threshold of 200 to 250 to define relatively high calcium excretion rates. Some people will also standardize that to weight in order to make these numbers more applicable to pediatric patients and patients of various size. But roughly 200 to 250 milligrams of calcium is considered a threshold for hypercalciuria. Okay, so these patients will typically have much less than 200 milligrams of calcium in a 24-hour period. But like I said, we often use the calcium to creatinine clearance ratio, which we described as essentially a fractional excretion of calcium expressed or calculated from a 24-hour urine calcium, 24-hour urine collection as a means to more accurately distinguish hypocalciuria in patients with varying GFR, right? Remember, low GFR would predict relatively lower urinary calcium excretion rates. The calcium to creatinine clearance ratio corrects for any changes in GFR in interpreting urinary calcium excretion rates. Okay, so we generally use less than 1% for a calcium to creatinine clearance ratio to define hypocalciuria, which would be typical for FHH. And then patients with greater than 2% would be more characteristic of the hyperparathyroidism, the primary hyperparathyroid patients. So you see there is a gray zone between 1 and 2% calcium creatinine clearance ratios where it's not easy to distinguish between the two. Don't forget, if there's a concomitant vitamin D deficiency, correct that vitamin D deficiency in order to accurately interpret the calcium to creatinine clearance ratios in distinguishing FHH from primary hyperparathyroidism. Now, there is this interesting and, let's say, variable manifestation of FHH that might also help you distinguish between FHH and primary hyperparathyroidism, and that is this mild hypermagnesemia that may manifest in FHH. So let's make sense of that. And that maps back to some discussions around Bartter syndrome. So we're centered about the thick ascending limb in describing why these individuals might have this hypermagnesemia. Okay, this is one hypothesis. Don't forget that magnesium is reabsorbed through the paracellular approach as well and is regulated by claudins. Maybe you can simplify things and describe this phenomenon simply through this recognition. Let's talk about thick ascending limb biology in order to re-emphasize some physiology that is relevant here as well as for Bartter syndrome. Okay, I'm going to just use our tubular transport map since my pictures are getting a bit cluttered. So let me get there. So here we are in the thick ascending limb. And you'll recall that calcium sensing receptor is a modifier of apical transport in the thick ascending limb. And indeed, it is one of the Bartter syndromes. We'll describe this again in one of the phenomenon present in autosomal dominant hypocalcemia. So autosomal dominant hypocalcemia is again an activating mutation of the calcium sensing receptor. Let's talk about that inverse real quick because that is essentially akin to one of the Bartter syndromes. So when I have an activating mutation of the calcium sensing receptor, I inhibit apical transport via NKCC2, that is the transporter that's inhibited by loop diuretics, as well as ROMK. Okay, so when I have autosomal dominant hypocalcemia, again, an activating mutation of the calcium sensing receptor, I can have a bit of K wasting. It can mimic Bartter syndrome. Okay, if I knock out both calcium sensing receptor, so I have that would be the classic autosomal recessive Bartter syndrome that manifests with profound salt and potassium wastage. Autosomal dominant hypocalcemia is a mutation of only one of the two alleles. And again, I can have mild degrees of K wasting with autosomal dominant hypocalcemia. Okay, now let's talk about the inverse. Well, let's develop the Bartter syndrome, and then the inverse is easy to understand. So with Bartter syndrome, I often have defects of calcium and magnesium handling as well. I have hypercalciuria and magnesium wastage. Okay, so again, autosomal dominant hypocalcemia and Bartter syndromes would tend to have magnesium wastage. So if I'm talking about the inverse of autosomal dominant hypocalcemia, which is again an inactivating mutation of the calcium sensing receptor, you can hypothesize that I will have this, let's say, magnesium avidity or increase in reclamation rates of magnesium. And that may explain, again, this relatively higher magnesium concentration in the serum that may manifest with FHH. Okay, we can think of it in terms of just this increase in upregulation of paracellular transport of these divalent cations throughout the nephron, both calcium and magnesium affected, or we can kind of focus on thick ascending limb transport, review some of the biology of Bartter syndrome in order to understand it from a different perspective. Okay. So this is variable. It's not a very reliable predictor of FHH, but it is sometimes seen. Okay. Genetic testing is also available. If you can't distinguish the primary hyperpara from the FHH, you can resort to genetic testing. However, that should be the minority of patients. You should not be using as a routine every primary hyperparathyroidism before you finalize that diagnosis. You do genetic testing in all of those patients. That would be overkill. It should really be reserved for these patients with intermediate calcium to creatinine clearance ratios or otherwise uncertain diagnoses. Treatment will generally be conservative management, just basically observation. Any questions about FHH before we move to tertiary hyperparathyroidism and lithium therapy? Let me remind you, these are all situations in which I have hypercalcemia with a PTH which is elevated overtly or inappropriately normal, so unsuppressed PTH. So again, here we are in the algorithm, higher unsuppressed PTH. We've talked about FHH. We've talked about primary hyperparathyroidism. We've talked about briefly this neonatal severe hyperparathyroidism. Let's round out tertiary hyperparathyroidism and lithium if there are no questions. All right. Then tertiary hyperparathyroidism is typically an individual that manifests hypercalcemia, hyperparathyroidism, and typically advanced chronic kidney disease. These patients have had secondary hyperparathyroidism for a prolonged period. We talked about what that does on a histologic level to the parathyroid gland. There's an increase in parathyroid gland mass, and there's also areas of adenoma that start to appear in this background hyperplastic tissue. Okay. And then at some point, this adenomatous tissue becomes autonomous and essentially has hypercalcemia with an unsuppressed PTH. Okay, so we've talked about this portion of the pathophysiology. I can move on. Okay, so treatment is typically going to be with cinacalcet, calcimimetic, or there's an injectable form of calcimimetic that's now available and can be given in intermittent dialysis patients. And then uh, with uh, with medical therapy failure, there can be referral for surgical therapy. I need to modify this in your field guide. You should not be thinking of only surgical parathyroidectomy for only medical therapy failures in tertiary hyperparathyroidism. This is worded incorrectly. Some people have done a cost-benefit analysis and determined that when you have individuals who have reasonable longevity that's predicted, right? Let's say a relatively healthy hemodialysis patient, the number of years of cinecalcet therapy, the side effects of cinecalcet therapy, which includes nausea, that's typically a dose-limiting side effect of cinecalcet, the expense of cinecalcet, the polypharmacy from cinecalcet therapy, should should lean you towards surgical hyperparathyroidism in the young hemodialysis patient or a peritoneal dialysis patient. So patients with, again, lots of life years ahead should be considered for surgical parathyroidectomy. In this case, it's a subtotal parathyroidectomy that's performed, or a total parathyroidectomy with autoimplantation, where in the forearm they put some gland back in the forearm. Now, let me say that sometimes this autoimplantation doesn't work. Many high volume centers, for that reason, store extra parathyroid gland in their freezer so they can go back and get the patient's parathyroid tissue and reimplant parathyroid tissue if that autoimplantation does not take. So often patients with tertiary hyperparathyroidism will have a period of hungry bone. We'll go over that when we talk about hypocalcemia. But sometimes these individuals will have sustained hypocalcemia because they do not have sufficient residual parathyroid gland activity. And in this case, surgeons will either reimplant tissue, or if they did a subtotal parathyroidectomy and left an insufficient amount of gland back in the neck, they will again implant tissue into the forearm in order to correct this sustained relative hypoparathyroidism. One last point to make about the autoimplantation procedure. When you have a patient who has autoimplantation, you have to be cognizant of where this parathyroid gland has been replaced, and make sure when you're assessing PTH in that individual, you're doing it through assessing PTH from their fistula or graft, or through their catheter if they have it. If you're doing a peripheral stick, do not do it on the side of the autoimplantation, because if you sample blood from a vein that is downstream of that autoimplant, you'll have this very high PTH level, which doesn't make sense for the patient. Okay, so again, if you're assessing a patient with autoimplant tissue and you're doing it through a peripheral stick, make sure you use the opposite arm. All right, questions about the management of tertiary hyperparathyroidism. That's a common problem that you're going to encounter as a practicing nephrologist managing dialysis patients. Any questions before we move on? All right. Lithium therapy, it can also result in a hypercalcemia with an unsuppressed PTH. So in this situation, you have lithium that is interfering with the function of the calcium sensing receptor, or really, it's the signaling molecules that are downstream of the calcium sensing receptor, which are modulated by lithium therapy. It essentially results in a phenotype that mimics from FHH. That is, there is a decrease in sensitivity of the calcium sensing receptor through modification of the signaling molecules downstream of the calcium sensing receptor. This results in, again, a relative high PTH and a relatively high serum calcium. With sustained lithium therapy, you can develop overt primary hyperparathyroidism from either foregut hyperplasia or the appearance of adenomas. So initially, it's a effect on the calcium sensing receptor that is reversible with withdrawal of the lithium. However, some patients will proceed into progress into overt primary hyperparathyroidism with an adenoma that's appearing or foregut hyperplasia. Okay. Questions about that before we move on to other causes of hypercalcemia? In this case, hypercalcemia that's driven by vitamin D excess. Okay, let's talk about our granulomatous diseases. So in these individuals, they have hypercalcemia. These are typically hypercalciuric patients as well with their associated symptoms, meaning these patients will be predisposed to kidney stones or nephrocalcinosis. They may be predisposed to symptomatic hypercalcemia like constipation or just an overall feeling of unwellness. These individuals will have granulomatous diseases. What's happening is that calcitriol is produced outside of the 1-alpha hydroxylase activity of the kidney. Activated macrophages also have 1-alpha hydroxylase activity. And so these individuals will have autonomous production of calcitriol. Autonomous meaning it is not regulated by PTH. There's less inhibition through FGF23 levels. Remember, these are activators. Well, PTH is an activator. FGF23 is an inhibitor of 1-alpha hydroxylation. You'll recall that. But again, when I have this extrarenal production by activated macrophages, you get sustained elevations in calcitriol, even though in these scenarios, PTH will be suppressed, right? Because they have high calcium, they have no problems with the calcium sensing receptor. So one would predict that these individuals will have suppressed PTH, and they will have a high calcitriol level that is especially remarkable because their PTH is suppressed, okay? Hope that makes sense. Again, sarcoidosis is a classic cause of this phenomenon, granulomatous disease producing hypercalcemia. But other granulomatous diseases like tuberculosis, fungal infections, and then we've had a couple of instances of mycobacterial infections in patients with HIV who have immune reconstitution. So as a manifestation of iris, right, you have an HIV patient with disseminated MAC. They are not hypercalcemic until they're treated with HIV medications at the point of immune reconstitution. They now have an inflammatory response to the disseminated MAC. They now have production of calcitriol. And so as a manifestation of iris, they develop hypercalcemia, and some of them even develop granulomatous interstitial nephritis. We've had a couple of cases of that as well, where GFR starts to drop as a again, immune reconstitution syndrome. That allows me to describe that perfect storm once again, as I described in the past, where calcium spike. Many patients with, again, sarcoidosis who have this calcitriol excess have a modest elevation in calcium. Now, when they develop sarcoid infiltration of the kidney and GFR starts to drop, the high calcium blasts off because they have a reduction in urinary calcium clearance, right? Because again, GFR is a major determinant of urinary calcium excretion rates. So when they develop renal impairment, either because of iris or sarcoid involvement of the kidney, that's when calciums rise astronomically. Okay. I've talked about the pathophysiology. Again, activated macrophages expressing 1-alpha hydroxylase activity. There is, because of this vitamin D excess, increased absorption of calcium from the gut, resulting in hypercalcemia and hypercalciuria. There is also an increase in intestinal phosphate absorption. High levels of calcitriol also activate osteoclasts. So there's an increase in bone resorption as well. So even in the fasted patients with granulomatous disease or severe or calcitriol excess will still manifest hypercalcemia. They do not necessitate only dietary calcium absorption as a cause of this hypercalcemia. PTH is suppressed, and so these individuals have another reason for hyperphosphatemia, not just the phosphate absorption from the gut, but the suppressed PTH will suppress the uh, uh, the let's go to the proximal tubule so you can get the visual. Remember again, PTH is a negative regulator for apical phosphate transport, right? So high PTH results in phosphaturia through inhibiting apical membrane phosphate transporters. So when I have PTH deficiency or low PTH levels, because of the calcitriol and hypercalcemia or the calcitriol and calcium excess, then I have avid phosphate reabsorption through these apical transporters. And so not only is the high phosphate reabsorption from the gut a player in the hyperphosphatemia, but I also have high phosphate reclamation by the kidney as an explanation for the hyperphosphatemia. Calcitriol levels will be elevated. Again, PTH levels will be suppressed. Treatment essentially revolves around treating the underlying disorder, treat the sarcoidosis, or the granulomatous disease. In the short term, even if I have granulomatous disease from iris or tuberculosis or histoplasmosis, glucocorticoids can be used in the short term, even for these infectious diseases, to bring down calcitriol production. So regardless of cause, if I have activated macrophages, use of glucocorticoids will reduce calcitriol production. So you can use it even in these infectious diseases if you're simultaneously treating the infectious disease. All right. Let's move on to calcitriol or vitamin D overdose. So these individuals, this is actually not that uncommon, especially because, there's a lot of health food claims or supplement claims that patients are exposed to. And so it's not uncommon that I see patients with vitamin D overdose in my stone clinic with a mild degree of hypercalcemia. So these patients will present, again, similarly hypercalcemic, hypercalciuric, hyperphosphatemic, right? That hyperphosphatemia is well explained because of, uh, um, so I've said hyperphosphatemia and granulomatous diseases as well, is explained by that increase in intestinal phosphate reclamation as well as suppressed renal phosphate excretion. And so these individuals may have either a uh, vitamin D precursor excess, right? If you're taking cholecalciferol or ergocalciferol, remember those those are 25 hydroxylated, right? So even though I give an excess of ergo or cholecalciferol, what we measure is 25 hydroxylated vitamin D. So this may be high in a patient that has vitamin D overdose. This is active at the vitamin D receptor. It is just less potent than calcitriol at the vitamin D receptor. Both activate the vitamin D receptor. If I take enough of ergo or cholecalciferol, this excess of 25 hydroxy vitamin D can activate the vitamin D receptor, resulting in all of the phenotype that was described. And in some cases, I might have excess of calcitriol. That is often iatrogenic because practicing nephrologist is giving too much calcitriol, either in the clinic or in dialysis. So sometimes we're giving calcitriol specifically. The brand name for that is Rocaltrol. Other times we're giving other forms of calcitriol that have less calcemia, or that are less hypercalcemia inducing, like doxycalciferol, which is Hectorol, or paracalcitol, which is Zemplar. Those are the brand names of these drugs that are used predominantly in the dialysis clinics. All of those can cause hypercalcemia when given in excess. Again, so it can be through the use of supplements by the patient, or iatrogenic by the physician prescribing too much active vitamin D. Again, evaluation will include excess of 25 hydroxy vitamin D if it is through ergo-cholecalciferol overdose. These patients will tend to have relatively normal amounts of calcitriol because, remember, PTH is suppressed, hypercalcemia suppresses PTH, and PTH is a regulator of 1-alpha hydroxylation. Right, so if you have excess of these precursors, calcitriol may not necessarily be high. Right. Again, calcitriol excess can be also simply confirmed by 125 vitamin D activity assays. If it's because of calcitriol overdose, that will not be elevated if you gave paracalcitol or doxycalciferol. Treatment will generally just be stopping these drugs. However, the time course is different if you have calcitriol excess versus the cholecalciferol or ergocalciferol overdose, because ergo and cholecalciferol have relatively long half-lives in comparison to calcitriol, so that hypercalcemia of ergo or cholecalciferol overdose may be sustained for a longer period of time than the patient who just got too much calcitriol, in which stopping the drug might be sufficient. Sometimes, because of that prolonged half-life of ergo and cholecalciferol, you actually have to give anti-resorptive therapies in order to bring down the calcium if it's extreme elevation. Moving on to some, let's say, esoteric forms. I won't belabor, just allows me to talk about some of the biology, which we will touch on. We'll touch on different flavors of some of this biology as we discuss disorders of phosphate transport even. So let's go over idiopathic infantile hypercalcemia. This is an individual who has hypercalcemia, hypercalciuria. It's going to be a patient who has high levels of vitamin D, since it's in this portion of our conversation, right? So these patients will have suppressed PTH. These patients will typically, as the name implies, present in the early years of life. And these patients have, as their pathophysiologic explanation for this manifestation, they may have mutations in this inactivating enzyme, right? 24-hydroxylase enzyme is your inactivating enzyme for these vitamin D, these forms of vitamin D, right? So this is your 24-hydroxylase enzyme, which deactivates these forms of vitamin D by adding a hydroxyl group to the 24 position of this steroid backbone, right? And I can activate calcitriol similarly. I now have these 3 hydroxyl groups, 125 plus the 24-hydroxylase step, which inactivates calcitriol, right? So it stands to reason that if I have a mutation in 24-hydroxylase activity, then I will have an excess of these vitamin D forms, right? Now I might have a different mutation in a phosphate transporter, right? Remember, phosphate transporters mediate phosphate reclamation. in the proximal nephron, right? We're in the proximal tubule here, describing apical transporter here, in this case, sodium phosphate transporter 2A, abbreviated or described as NAPI, right? NA, NAPI, PI, meaning inorganic phosphate. So NAPI 2A is the transporter that might be mutated in some forms of this infantile hypercalcemic syndrome. Why would this result in calcitriol excess, right? If I have a problem, a primary problem with phosphate wastage, then I develop low serum phosphate. If I develop low serum phosphate, then my FGF23 levels are going to be relatively low, right? Because high phosphate stimulates FGF23 production. So again, if I have renal phosphate wasting and I have low phosphate, then I will have relatively low levels of FGF23. Remember, FGF23 is an inhibitor, or it regulates 1-alpha hydroxylation. So if I have low levels of FGF23, then I will have, um, um, let's say, unleashed 1-alpha hydroxylase activity, and therefore I would produce more active vitamin D, that is more calcitriol. These patients will often present with, again, hypercalcemia and hypercalciuria as a more prominent feature. So we'll talk about this as we talk about the phosphate wasting syndromes. Some of those phosphate wasting syndromes, when they're from phosphate transport defects, will present with hypercalciuria. We'll talk about that, okay, as we talk about hypophosphatemia. So I'm anticipating that discussion in our hypophosphatemia conversation. Okay, so again, low FGF23 activity results in increased 1-alpha hydroxylase activity. All right. So in these individuals, PTH is suppressed, urinary calciums are going to be high. These individuals with 24 hydroxylase mutations will have an increase in 25 hydroxy vitamin D to um, uh, 24 hydroxy vitamin D. So you can send that as a screening test for 24 hydroxylase deficiency. So you look for relatively high amounts of 25 hydroxy vitamin D and relatively low amounts of 24-25 hydroxy vitamin D. Some use a ratio of around 80 as a threshold for this diagnosis. Okay. Let's go back to just make sure I've covered the clinical presentation fully. Most, again, present in childhood. However, milder phenotypes have been described where adult presentations are manifest. These individuals may have a problem with high serum phosphate when they have excess of vitamin D activity from the 24 hydroxylase deficiency. Remember, vitamin D regulates calcium absorption from the gut, but it also regulates phosphate absorption from the gut as well. And then we've already talked about how high calcitriol levels, high calciums will suppress PTH, and therefore these patients will have lower renal clearance of phosphate. Serum phosphate will be high in some of these individuals. However, they would obviously be lower in patients who have a defect in apical transport of phosphate by the proximal tubular epithelial cell. Okay. These patients, from their sustained hypercalciuria, will have varying degrees of kidney stones or nephrocalcinosis. Questions about those? Again, vitamin D excess syndromes. We got to talk about the regulation of vitamin D production through FGF23. Those concepts will be relevant as we talked about our disorders of phosphate homeostasis in future conversations. So it would behoove you to digest that information. All right. In our last few minutes here, let's cover at least a couple of these hypercalcemic syndromes that are often acquired. They're not that uncommon. You're definitely going to encounter these throughout your training experience. And of course, as a practicing nephrologist, you'll see these plenty of times. So let's talk about in hypercalcemic syndromes. PTH is suppressed. Vitamin D is not in excess. A classic description of this would be the so-called humoral hypercalcemia of malignancy. So let's review where we are in the algorithm here. Let's also just briefly cover the ground which we discussed in the vitamin D excess syndromes. I have hypercalcemia with PTH that's suppressed. So we described some of these instances in which I have excess of 25 hydroxy vitamin D or 125 hydroxy vitamin D. These might include the granulomatous diseases. We've talked about several of these things. We're going to talk about some of these others at the end of our conversation on hypercalcemia. We'll pick up some of these others where I do not have excess vitamin D or 25 hydroxy vitamin D or calcitriol levels. We'll cover some of these. Here we are now talking about humoral hypercalcemia of malignancy, which is a disorder of PTH-related peptide, right? Pheochromocytoma also is a syndrome in which you can have elevations of PTHRP. So again, these individuals have hypercalcemia with suppressed PTH. They typically have obvious cancer, and these are not because of excess bone resorption from bone metastases. This is because of this overproduction of PTHRP. Phosphate will be low because PTHRP, just like PTH, regulates proximal tubular phosphate handling through the PTH receptor, right? PTHRP can also activate the PTH receptor, and so these individuals will tend to have low serum phosphates. Various tumors produce PTHRP. Classically, these are squamous cell carcinomas, renal cell carcinomas. Breast and ovarian cancers are another group that can produce PTHRP. I think I talked about the fact that that sometimes there's elevations in calcium in the pregnant individual who has, because breast tissue can produce an increase in PTHRP during lactation. But again, breast and ovarian cancers also can produce PTHRP. Lymphomas more commonly are associated with calcitriol excess as a main cause of hypercalcemia. However, it is possible that some lymphomas produce PTHRP, but that is not the most common way that patients with lymphoma present with hypercalcemia. Typically, that is because of calcitriol excess from this overproduction of calcitriol or this increase in 1-alpha hydroxylase activity in lymphomatous tissue. Again, PTHRP binds the PTH receptor in osteoclasts and in the renal tubules. This results in bone resorption. This increases tubular calcium reabsorption. The phosphate wasting is also manifest. The evaluation results in the conclusion of PTHRP being elevated, so that's a fairly direct diagnostic test to make that conclusion. Let's go over at least one more, before we end here, osteolytic hypercalcemia. How does this differ from this humoral hypercalcemia of malignancy? This is the case in which I have bone metastases or the myeloma that is resulting in bone resorption. Okay, so these individuals have bone metastases or myeloma in the bone that results in increased bone resorption. Phosphate may be high in these individuals because, again, PTH is suppressed. There is no excess of PTHRP to suppress phosphate reabsorption in the proximal nephron. These individuals may have high phosphate because, again, PTH is suppressed, and the the lysis of bone, or the reabsorption of bone, releases calcium and phosphorus to the extracellular fluid, right? Bone is made of calcium and phosphorus. Again, etiologies are malignancies with spread to the bone. Breast cancer is a classic one that spreads to the bone. However, there are others. Renal cell carcinoma can spread to the bone. There are certainly others. These individuals, prostate cancer is another one that can spread to the bone. These individuals uh, um, typically have obvious cancer. It's not subtle. Myeloma patients may, however, have a more subtle presentation where they have hypercalcemia without overt, bone pain or bone fractures. Myeloma cells produce interleukins that activate osteoclasts, so it does not require massive amount of lytic bone lesions in order to manifest hypercalcemia. The myeloma itself, the myeloma cells, the plasma cells, produce, again, substances that activate osteoclasts. And so, again, you may not have a bone that is chock full of myeloma cells before you manifest this hypercalcemia. All right, I've described this statement. Guess we can end there.